This evening we've got a panel of experts and we just wanted to explore some of the issues that we thought arose from the play and maybe delve in a little bit more into the themes and the clinical aspects of the disorder as well. So I'm going to start by asking a few questions to the panel and then we'll open it up to the audience if you have any questions yourself. So I'll start by introducing everybody. This is Dr. Nicholson. He is a NIHR clinical fellow and he's researching functional neurological disorders. He is also a consultant neuropsychiatrist at South London and Maudsley NHS Trust. So he's an expert in the disorder, in functional disorders, and he was involved in the play at the beginning, I understand. We also have Sophie, who you recognise. Sophie's the lead actress in the play. James Yeatman here co-wrote the play and also directed. And then at the end here we have Kim Hearne, who is the CEO of Functional Neurological Disorder Action, which is a charity which was set up to support patients with functional neurological disorders. So that's the panel. So I wanted to start with you, James. You obviously were there at the beginning. I wanted to ask you kind of what the inspiration was to play, why conversion disorders, functional disorders? What was the inspiration?
I wanted to do a play about medicine because I come from a very medical family. So my dad is a doctor, my brother's a doctor, and my mum is a speech therapist. And I wanted to get involved in the family business without training to be a doctor. So. And I got and I thought, what would irritate them the most? And so I wondered if there were diseases that you could get that were undiagnosable. And I asked my dad and my brother, and they looked at me like I was an idiot. And then I went and asked some other doctor friends. And a friend of mine who works at UCH actually pushed me down a kind of towards functional conditions. She sees a lot of people with functional conditions, and she said that they're very, very difficult to treat, and also that they're these very murky things that kind of classically are modelled as kind of psychiatric conditions, but that a lot of patients contest that diagnosis, and that a lot of patients can then end up in a very kind of dodgy medical rabbit hole where they kind of get shunted from kind of department to department. And that, like, if you kind of look at that, you can start to kind of look at how we structure meanings about kind of illness and things like that. And so it seems kind of interesting that, like, most illnesses that we look at have a story behind them. You know, that if you get TB, you can look at a little microbe, which is the TB bacillus, and that's what gives you, I hope I pronounced that right, but that gives you, this is I'm starting to wade into medical, I'm glad my parents aren't here actually, but you can start to, you can tell quite a clear story about how you've ended up with the particular disease, and that this seemed to be not so simple. And then I got in touch with some patient groups who spoke to me about their experiences of FMD, and also put me in touch with Tim, and I badgered Tim for a while, and then met him, and he talked to me quite a lot about that. So yeah, so it was wanting to find a condition that could make you look at, like, the ways in which in what healthcare and what illness means in our society, and what illnesses are given sympathy, and what illnesses are understood, and then what illnesses are kind of looked at with a little bit more arm's length. So that's where we started. And also my dad he's a teacher's medicine, and so he does the OSCEs, the things at the beginning where you get actors pretending to have illnesses, and that seemed like a total theatrical gimmick, basically. It was like, I've heard lots of stories of actors that do them, and they all sound absolutely ridiculous. So we thought we could get some laughs out of it. And so that seemed like a good excuse to make a show that kind of destroys all profundity to it. But yes, so that's how it began. Yeah, that's how we started.
Okay. And it's, I got the impression and that the play itself sort of took shape in rehearsals? Is that?
Yeah, so we have with the way we make shows is through quite a lot of research, and then we do little periods of working with actors and performers and trying to kind of find a story. And it quickly became clear that we needed to tell the story of somebody who like that kind of journey, which is true for anybody with an illness, which is that feeling of how you get a physical symptom, how you recognise a physical symptom as something which is alien, and then the journey that you go on to having that diagnosis is such a kind of key part of medicine, and so we wanted to find a journey. And then also Al, who co-wrote the play, had used to write for Holby City and had kind of got a bit frustrated with Holby City, so he kindly wrote us a spoof medical TV drama that she could have been on, and yeah, so we just kind of inched our way through it, basically. It's quite an odd show. It's quite an odd story to tell, because medical narratives tend to end in death or you get better, right? That's the kind of, those are the stories that people tell about it. And we were always wanted to resist. I can't remember what the statistics are, but the rates of recovery from FMD are kind of low, and what happens, and some patients do I don't want to tread on anyone else's stories here, but I know that some patients do recognise a kind of stress or psychological or whatever cause, but a lot don't. And what happens if you never recognise that cause and never have that cause? How can you get better? So we always wanted to put lots of things in there where you could kind of, it is her mum died, or it is because she has a stressful job, or it is because she broke her wrist when she was 14, or any of those things, but we never wanted to say that was the answer. So that's why it's got a very flat ending. It hasn't, it's great.
Okay, and that leads me on to Sophie. I think it was a very physically demanding role. I'm just wondering how you experienced playing this particular part. And also, maybe if you could tell us a little bit about the kind of research that was involved in taking on a role like this.
Yeah, it was like, I guess partway through rehearsals, I started to think, oh my God, why do more people not have this? Like, how do we function? Like, it's kind of incredible that I'm able to walk out and talk, and when you actually start to unpick it and start to think about it, it's just amazing how our bodies work. And so it was strenuous. It was more strenuous in the first version, I think. But it's amazing how, so for example, just doing that, like for a certain amount of time, you know, when she puts the Botox injection in and then I release my hand, like, it's really weird, but I actually have to tell my hand to open. It's really, I'm going, please open, please open. And of course I know it's going to open, but it's just little moments like that that make you realise sort of what you're dealing with in a way. And it must be, and also I've got I realised how exhausting it is. Like, just doing that thing from the chair to here, the closest thing that someone said to me, it's like you're fighting yourself. It's like it's like a ghost fight that's happening. When you actually concentrate and try and do it, I'm absolutely knackered by the time I reach that bed. Then I have to sing a song. So it's been really eye-opening. Really, I'm so pleased I got to do it, because I wouldn't have known about this stuff, and I wouldn't have met you guys and things. And yeah, it's fascinating. Like, it's important that people know it's discussed more and it's in theatre more. So just to be part of it, I feel very lucky. I wasn't supposed to be. I was supposed to be someone else.
Yeah, previous actress got ill.
No, but it was fated, because the character was called Sophie before I came on board, so it was meant to be.
Okay, and move over to you, Kim. I mean, this is, I think, the second time you've seen it before.
Yeah. Just bringing me all well up anyway with the second one as well, because obviously my personal experience, I was diagnosed in 2014. I was in hospital for a week because they thought I'd had a stroke, so I lost. Sophie, every time I was watching you, I was like, oh, I know what she feels like. But I obviously have recovered. But personally, yeah, I did get quite seriously ill. I did get the functional dystonia. I lost all ability in my legs. It took me about 2.5 years to start walking again. So it did take a lot of physiotherapy, rehabilitation. I may have been stressed, but I have no trauma, and so does a lot of people that just don't know. So the focus really needs to be on moving forward, not necessarily why it happened. And I think now this is the route that the doctors are taking now to move forward. So so the first thing you do, you get told you've got a condition. I got a website written on the corner of my newspaper. You go Google it. And you Google and you Google and you think you've got everything, and you go to doctor after doctor. I didn't get seen in London, but my neurologist discharged me, so I don't want to. And found some support groups on Facebook, got involved with them, got talking to. There's just hundreds, thousands of people that have got this different severities. You've got people like me that will just have a few blips every now and again now, but you've got people severe seizures in wheelchairs, and everyone just wants to get better. There's a misconception that people, that especially with invisible disabilities, if they have cognitive problems, things like that, they do. Everybody wants to get better, but no one can give the answer, which is great how more research has been doing. So anyway, went on support groups, started to help people. I was quite ill, met with people in the same position, and then a year last October, we became the first registered charity in the UK for functional neurological disorder. We're all volunteers, and now there's 4 charities in the UK, and it is making a difference, I think, having that charity status now. Support groups on Facebook, there's some leaflets outside, and so we're there to help people, to support.
I wanted to ask you, I mean, if you met someone now who was kind of beginning to feel those symptoms, would you have any advice for them, now that you're sort of halfway through the journey, or you're sort of...
Yeah, I mean, the main problem we have is dismissed. They're just dismissed. People have just got no care whatsoever, and obviously we can't give medical advice, but we're like signposting. You must go and tell them you've got to do this. We're just trying to make neurologists not discharge patients and look into physiotherapy. We've got a website as well, and obviously there's neurosymptoms.org as well. So yeah, it's just as much whatever direction they need to go in, but it is about getting better. It's not a case of, it's finding those resources to help, but getting better, or at least managing symptoms better. Because I've not met somebody who is better.
Yeah.
So that's just I've met a few thousand. But it's just coping.
Yeah. Okay, and Tim, I mean, you're an expert in the field. Could you give us a bit of an overview maybe about how we understand this, some of the theories behind the disorder, what's the current kind of clinical understanding?
Yeah, so the model has changed a bit from, as you mentioned, from something that historically has always been thought to be 100% trauma-related and psychiatric and psychological in mechanism to now a more complex sort of multifactorial model that might be different in some people and in other people. So I think it's still important to look for psychological stressors and traumas which are relevant for some people for sure, but not everybody. And I think that's what the play does really nicely, is bring that out. And also the fact that it's a potentially chronic severe illness. But the big problem always is that it's misconstrued for feigning, for not being a real disorder, and that's, even if it's not said explicitly, it's the way people are treated in a very dismissed sort of way. I think everybody who's gone through a sort of treatment finds that at some point. So there's a big way, it's not just the public you need to understand, there's lots of doctors, nurses, physios, although physios are getting pretty good now, so need to understand that. But I think it's also, Sophie was mentioning about the more you think about your body, the more it breaks down. So a lot of the contemporary theories about how the sort of interaction of the sensory motory system, the more you attend to it, the more it breaks down. So the sort of thin end of that wedge is, say, someone in a World Cup final shooting a penalty, and that they'll kick it 100% into the goal, but under stress or when they start to focus on their body, it starts to break down. So that firstly it gives an overview for stress interacting with the motor system, but also how attending to it or thinking about it makes it start to break down. So those are some of the current sort of theories, but also we're looking into the genetics of it, how because I think it doesn't particularly run in families, but I'm sure there is a personal susceptibility to it. But these things are very common. About a third of medicine is functional, so that's in neurology and every other setting. So they're very common disorders. So there is some vulnerability that then, through your life experiences perhaps, is mediated, and then there might be a final trigger, which may or may not be something we can detect psychologically. So that's the current theories.
And I mean, if a patient came to you tomorrow morning, what's your treatment, doctor?
Well, I'm a neuropsychiatrist. I'm a psychiatrist who specialises in this overlap area of neurology, and I did some neurology training before. It's because I knew this is this sort of mind-body sort of interaction is what's of interest to me. So I normally see people once they've already been diagnosed by a neurologist. I'll sometimes see someone initially, but the big movement as well has been not just ruling out that it's not MS or something else. It's finding these positive signs, which are so again well brought out in this play, because that's critical. And the big shift has been using those positively and explaining them to patients, and again, as Harry does so well in this, and sensitively and with compassion, and explaining firstly this is how we know it's not physical, organic in the traditional sense, but also that it's something different. So they don't just think, oh, okay, well, I want to now. There must be some other test I can have, but I haven't had every test yet. Of course, there's 1,000,001 tests you can have, and some of them will throw up false positive results. So I think getting the positive diagnosis is critical, and then sometimes just understanding the disorder can make it, because it's like it could be seen as a vicious cycle of attention to the body and how everything starts to break down. So sometimes just knowing what it is can make it go away. It's pretty rare, but that can happen. And then it's a mixture of rehabilitation through physiotherapy, and that's getting increasingly specialised. So not just physiotherapy that you do for a stroke or something else. It's using particular techniques that are specific for FMD or helpful. So undoing sort of particular, or sometimes reflex automatic movement is easier than when you're trying to do it. So people can often be. There's a very good video of an Australian patient who couldn't walk but could put on a treadmill, could run. Or people can walk backwards and forwards, or if you start to sort of slide your feet along the floor, you can start to move more normally again, but you can't actually take that first step. Your brain almost can't make that initial movement. And then obviously psychological therapies, cognitive behavioural therapy, and sometimes sort of more sort of psychodynamic stuff. It can be, but it's pretty rare.
And Kim mentioned prognosis. I mean, could you
Yeah.
give us a bit of an overview?
Yeah, it's very variable. There are people who do make complete recoveries. It's pretty rare. But I've certainly seen quite a lot of patients who, if not complete recovery, then pretty much that.
They wouldn't want support groups.
No, exactly. So it's a slight bias in people who, you might want to look back.
Take that back.
Yeah, exactly. So, but I think there's quite a good sort of meta-analysis of studies just recently, which has shown that about 40% of patients are the same or worse 7 years later. So that's pretty bad, and the levels of disability are the same as for MS or Parkinson's. So it's very severe chronic disability that people have, and it doesn't really get. It's fallen between mental and physical health, and patients have often rejected the diagnosis because it's been made poorly without explaining, and also with not treating it as a real disorder. And it's understandable that patients reject that. So it's sort of fallen between the gaps, and we're finally sort of getting the attention and respect it deserves.
Okay, well, there are more questions. I wanted to open it up to the audience. Does anyone have any questions for the panel? Yes?
Well, I'd first like to say thank you to everybody concerned. The dialogue, the direction, the acting is superb and so true to life. My background is I have a sister and she has 3 children who all suffer from FMD. So my question is to the doctor, and it's just something that I have often wondered about, and that is, do you think that giving patients, when they first present symptoms of FMD, medication, in particular epileptic type medication, when they have not got epilepsy, could possibly cause a worsening of the FMD in the long term, and bearing in mind the news yesterday of epileptic drugs being passed on to the action of epileptic drugs being passed on to the children and possibly even the grandchildren. Has anything been done on this for FMD, or do you think it is a possibility?
I guess firstly, giving medications initially, I think that depends on whether the doctors have made the correct diagnosis, because if they've diagnosed FMD, most people wouldn't prescribe medications for that. There's sometimes a pressure to do that if you're not sure. Sometimes you need an EEG to be definitive at the same time as the seizure. So that's the only way you can be 100% sure. We also need to not get into what, you can have both. This is another critical thing. You can have an organic disorder such as epilepsy and non-epileptic or functional seizures as well. So whilst there's uncertainty, it's not unreasonable to prescribe something. But generally speaking, and sometimes patients are very keen on having a medicine, and that can work in different ways. It can work directly on the disorder if it is epilepsy, but it can also, most sort of what we call CNS, central nervous system drugs, do reduce sort of anxiety and stress, so it can work in a different way as well. And obviously every drug has a placebo effect as well. So I think generally the other advice would be that if you're sure about the diagnosis, then it's not generally a good idea, or to be on it or try and come off medications you're already on. You say they do have side effects and harms as well.
Any other? Yes.
Would placebos ever work? Because like in the play, we showed first a Botox injection and had an instant improvement. And if they did work, are you ever allowed to use them anyway in the NHS?
Is that for me or something?
I'll answer that.
You jump on that grenade.
Don't let me answer it.
I don't know. I guess placebos work for everything. I mean, the power of placebo, and this is where it gets to the fascinating thing of the mind and body. Placebos can affect heart failure. They can make people. It's only when you do sort of shams. People do sham surgery for stuff where you pretend to take someone's kidney out or something, and they think I'm cured. And so the power of expectation of the mind is incredible. There is a school of thought, but not much evidence that the placebo is more effective in sleep than in other disorders, but that's not been proved or substantiated. And even if it is, it's because I think people used to historically use hypnosis to treat FMD when it was called hysteria at the times of Charcot and Freud. So I think it probably had to have a slightly enhanced, but it's certainly not the whole picture, and no one would. There are some complexities to the ethics of doing it. One interesting thing is that when you're making the diagnosis of the seizure variant, as I mentioned, the definitive diagnosis is to have an EEG at the same time as the habitual seizure. So it's the only way you can really be sure. There's lots of clinical features that can give you a fairly strong clue. But you just have to wait for a seizure to have to happen and be on a ward for a week or so. But there's now what we call activation clinics. There's one in Glasgow, one at King's where I work, where you can induce a seizure through suggestion to get the seizure. And that was initially, there were a lot of ethical concerns about that, but the important thing is it works even when you're being upfront about what you're doing, and that is nice because it shows that it's a completely subconscious process, whatever it is. So it sort of works in both ways. It firstly means people don't have to wait on a ward for a week and then potentially not even have a seizure and get the diagnosis, but it can happen, and it's effective in about 80% of people will have a seizure during those procedures. So it gets the diagnosis quicker, safer, and in this world, increasingly importantly, is that it's cheaper as well. It doesn't spend a week on a ward. There's a lot of rambling answers.
But the thing with placebos is that they can wear off, can't they? It's not a.
Yeah, and you've got the opposite of a nocebo as well. If there's a space for negative if things are handled badly as well. Well, you're expecting something negative.
Yes, here, Hannah.
Do you think part of the reason why, how do I phrase this? Do you think it's because we put doctors in such a high position in society that's also affecting why people dismiss so quickly, and they keep going back forward because they want to challenge that authority?
I think there's something, but for me, the big message of the play is that we should just trust the NHS and not seek private second opinion. Which is, I think there is a part of the problem in, it's very difficult to say whether these symptoms are more prevalent or whatever now than they were in the past, but there is like, I actually think there's possibly an opposite thing of that, isn't there, which is once you can start shopping for your doctor, you can get, once you, there's a funny thing, isn't there, which is that once you can start shopping for your doctor, and once you can say, I don't think that I've got this, I've got that instead, that you're on, it's like, which is understandable, but it's like, it puts you on dodgy ground, isn't it? When you go to America and you see that those adverts where they say, get your doctor to prescribe you these drugs, or get you to, like, you know, which encourage you to seek out better medical intervention, it becomes very, it's very difficult, and a lot, it seems to me, of the success of the, from what I've learned about it, which is obviously kind of wading into this like I'm a fucking doctor or something, but like, which is but which it becomes very difficult, doesn't it? Once you don't trust your doctor anymore, then it's very, very, very hard to treat a disease or a condition, or however it's the right word to describe it is. It's very, very difficult to accept your symptoms. Like, if you're in a kind of antagonistic relationship with your doctor, where you feel like your doctor's forcing you to tell you about how your mum didn't love you as a child or something like that, and you're saying, no, look, on the internet I've got bloody Lyme disease, there's like, that's not a place at which you can start to think about getting better, because that's where the argument is, isn't it? The argument becomes all about the cause rather than the way to move forward. And so about doctors' high position in society, it's tricky, isn't it? Because they, like, that's why we send them away to train for 7 years before. I don't want to diagnose myself. I want the doctor. I love going to the doctor and that you're like, here's my body, have a look at it here. And that I do it all every week. But that is, I've taught myself into a massive hole now. I don't know what am I saying. I think it's very, very difficult. You need you need medical authority, don't you? You need it, because otherwise, otherwise we're all just like flapping around. And also, medical authority has made a huge, huge difference to public health in the world. It's a very, it seems like, the problem with this condition, it seems to me, is that it doesn't fit into the system of medical authority that we have. And it's not, you know, you're either a psychiatric patient or you're a neurological patient, and there's very few neuropsychiatrists. Maybe we just need more
Tims.
Yeah.
But I think this is to pick up on a point that's quite interesting. I think, particularly because you explore it in the OSCEs, you see the different medical students coming in, some sort of with no authority and flapping, others almost having a sort of false bravado that's very doesn't feel right either, but to have that sort of confidence, because when you start off, it's a horrific thing those first few years as a junior doctor, because you want to give confidence, basically, because that's what they want and expect from you. But at the same time, when it's not, you don't believe it yourself, you almost have to act that confidence, or when you don't want to tell someone it's the first time you've done something, when you're seeing them, you know. So
I've done it on a dummy.
So, but you know, they actually really want you just to reassure them. So you don't want to pretend that it's okay or that you're brilliant at it when you're not. But it's a really, and you have to just feel your way about what's right at the moment and at the time.
It's really weird. I did an OSCE before the day
before the first rehearsal.
I just ran. I'd never done it before, I just suddenly got it. It was so bizarre. I was doing exactly what I was doing on first day of rehearsals, but I really got firsthand that doctor-patient interaction and how varied it was, and how, yeah.
I think the crucial thing, isn't it, is that medicine is not a medicine is an observable science, isn't it? But it is also a social relationship, and like the way in which we defined illness 500 years ago is very different to the way in which we define illness now. 500 years ago, if I got the plague, I would think that was God having taken his revenge on me, and I would go to a priest if the priest would see me, you know. And now we go to a doctor and we want scans and tests, but we also want. I heard this that GPs. You know, we all complain about GPs Googling things and all this kind of stuff, but that we want the GP to put their hands on us when we go, and people feel cheated if they haven't been touched by the GP, which sounds kind of like creepy, but I read this as a thing that people want that relation, they want that relationship with their doctor, and I think that's a lot of the frustration with the way medicine has gone.
Yeah,
is going. You want, yeah, exactly.
But the difficulty is when they don't know what to do, the patient wants medication, like you were saying, and the GP will just be giving out medication sort of thing, and then especially with like pain relief, I think people will be mortified at the amount of medication some people are on, and then it gets to the stage of morphine and they can't go any further. So a lot of people go to the GP and say, well, we're not quite sure, take some more medication or take some stronger medication. So it needs different sort of therapies, not just GP intervention.
But that's the relationship thing of medicine, isn't it? Is I go and see you and I want some pills at the end of it. And then you get enough pills and the GP says, oh, you're on pretty strong pills. Are you like, have you gone? Yeah, they think you're a junkie. You know, it's a very funny, it's a personal relationship, isn't it? And our relationship with healthcare is one of belief and of trust and of society just as much as it is one of like, maybe not. Yeah, my dad would disagree with this as much as it is one of science. But yes, anyway, yeah.
I think the other critical thing is time with patients, particularly functional patients, because just to explain and understand things, and I think there's this pressure GP people, I don't know how they see people in 5-10 minutes. And the easiest way to get someone out the door is to give them a medication and go and try that and come back if it doesn't work, rather than sitting and listening and exploring the problem. And a lot of doctors don't feel adequately trained or they understand these conditions enough to sort of really go with it. But it's okay, well, it's going to take half an hour. And for me, I have a luxury of seeing patients for as long as it takes. And sometimes I find 3 or 4 hours is what's required. And that time invested really is paid back in your relationship with the patient, but also into outcomes as well. So, but I think it's difficult in our current system.
Sorry, just the student at the back there.
I'm primarily here because I think it's a phenomenal piece of theatre, because the lady at the front at the start, it manages, as well as being entertaining and dramatic, also feeling very true to life. I'm also a helpful demonstration because I have similar functional symptoms which are triggered so I suppose my question for Tim or Kim is you were saying that the way that it's viewed has changed massively over recent years. I'd be really interested to know what the sort of back timeline is for that. Certainly in my case, I had symptoms going back to 1998 and was similarly passed from sort of department to department for 6 or 8 years. But the first time I'd ever heard the phrase FMD was seeing this show in 2016. And that was not, it certainly wasn't a phrase, but it also wasn't even a concept that was put forward to me in the early 2000s.
So in terms of how things evolved, I think things are still evolving. I think we've only managed to sort of educate 20-30% of doctors. The public still get, it's a complex thing for people to get their heads around. And I think the first base is just to explain it, and you see it in YouTube clips of people who post their own illness, and the comments are divided amongst sympathy, this is a real physical illness, or it's fake and it's feigned, and there's not this middle ground that it's functional. It's a subconscious, different process that's just as valid as anything else. And also for people to, it's again what's playing with that, is it can happen to anybody, it really can. And most people get a little bit of functional stuff in one part of their body or another through their life, but this is just, for some reason, it sort of grows, spirals out of control or gets stuck. So I think we're I think things have picked up. In the 60s, people even said that this doesn't exist anymore. So I think there was a sort of something out in the 60s and 70s where there was some research saying that if it's a false diagnosis, if you make it, they turn out to have MS. Most people have MS or stroke or some other undiagnosed disorder. But when you actually look at the details, that wasn't a very good study, but it was very influential, and we've only taken a while to recover from that. And also, growing a group of people who are interested in doctors, patients advocating makes a big difference as well. So there's a sort of home for patients.
So was FMD as a phrase known earlier in the 20th century?
Yeah, Charcot came up with the term functional because that was the time when microscopes are finding that structural abnormalities of the brain in people with Parkinson's or other disorders. So so if it's not a structure, then it's a function. But I guess it's a good term in that way, but also on some level every disorder is a disorder of function, otherwise it wouldn't be a disorder. So in some ways it's not the best term, but it's a brilliant term at sort of also meeting things in the middle. About it's not organic, it's not a standard neurological disorder or physical disorder, but it's somehow different. But then as we can make this diagnosis positively, that's as in we can identify it as in what it is rather than just what it's not. That's really been a big shift, and we're keeping people are finding new ways of making that diagnosis. And the dream is that we can have lots of positive tests in everybody, and every doctor in A&E treats people appropriately and gets the diagnosis in early and sensitively.
So, sorry, can I just follow up on that? So, Tim, do you think the reason Kip wouldn't have heard that is because maybe those doctors didn't know about FMD?
Yeah. Well, it wasn't really formalised.
It was conversion disorder.
Yeah. Well, then it functionally existed, but it wasn't the primary term. It was still one of many.
So
they just made the name.
Yeah, there's about 5 or 6, and the problem is every term becomes stigmatised as well, whereas this one is one that patients have got behind and identify with, and so therefore it's stuck. And it's also not making any particular, it's sort of agnostic about etiology. It doesn't say it's psychological or not, so it doesn't, and we've got to put a hand, we don't know exactly how this happens or why, because it's been neglected by research really. So
it's very surprising, but the Maudsley seem to use the term conversion disorder.
It's still the official term. There's functional and conversion still the official diagnostic terms in both ICD, the WHO criteria, and also the American Psychiatric Association.
Well, they're both equally.
Yeah, okay. but I think FMD will take over. I think it's.
But I think it's very unfortunate because conversion does so much mean.
Conversion
from psychological stress.
Yeah. So I think the FMD has I think most academics would agree that's the best term, but the fact that the patients have got behind it, it's sort of a done deal. That's the term we should use, and there's no going back from that. I think it's the great way forward.
I'm not changing our logo.
Okay, I think we have time for one more question, maybe, if we make it brief. Yes, lady in front, sorry.
What I am not getting is, I'm getting a picture that it is getting much more recognised and diagnosed, but what I'm not getting is a picture of successful treatment. Because you seem to reach a dead end when you've got a diagnosis. And where does treatment come in?
Well, treatment is finally happening. There's finally research. There's quite a landmark this year in the first ever multi-centre study. Because obviously, randomised controlled trials are the only way to tell whether something's an effective treatment or if it's just placebo. And the first ever big trial is happening of cognitive behavioural therapy. It's being run from the Maudsley, but an international, across the country, study. And they've randomised 280 patients, and that on its own is more than all the other studies put together. So normally a big drug study for a drug or a surgical intervention will have 1,000 randomised patients to try and detect the difference between two different groups, whether that's placebo or treatment as usual, doing nothing, or whatever it is. So we are finally getting some research, but doing trials is expensive. And we need to just, it's through getting awareness that we get people to actually fund these studies. So,
but it also seems to be that that route is not available if you're not 100% convinced that you haven't got some physical.
Yeah, exactly. But trials of physiotherapy are happening as well. So the same thing is going on, and the UK is actually leading the way with this. There's a few studies in America, but it's been relatively neglected by research in America. And in the UK, it's firstly had the academic interest and the experts, but also the funding. But they've done a pilot study of 60 patients for physiotherapy, which has been very effective. So there's specialised physiotherapy, and that's being run out of St George's Hospital. And I think they've just got funding, in fact, to do a big study as well. But also, we all need to think of different ways of treating it. How we think of medications, we were looking at sort of VR, virtual reality as ways of sort of retraining the brain. There's lots of different things that you can do.
There's more specialist clinics opening now.
Yeah.
I think what's happened as well is, what we advocate as well is for collaborative care. So I think, like you said, someone will go to neurology or someone might go to psychiatry, but now everybody's working together, so they're getting all bits at the same time, and there's more clinics now starting all over the country, really. I mean, there's areas that haven't got it. But yeah, so I think it's this multidisciplinary, and neurology and psychiatry are actually talking to each other now and working together, so it brings us out the gap. So,
isn't it the case that if you have MS, for example, which is a recognised organic disorder, you get physiotherapy and you get a joined up care from neurology and physiotherapy and drugs and all this kind of and that just doesn't exist for this.
Although really a lot of psychiatric symptoms occur in MS and they get a bit neglected. So the other way around.
We're also, it must be becoming more recognisable because we're having more people come who were diagnosed with, say, epilepsy or MS or something years ago, and now being re-diagnosed with FMD. So I don't know, I think it'll be looked at. And there's people that have got, like I've got hemiplegic migraine, so there's people that have it together with like MS, there's people that have got Parkinson's and epilepsy as well. So it's sort of, it's coming out of that end as well, not only as standalone, but also there must be some connection with other neurological conditions for it to dystonia as well.
So I think that's to end on a hopeful note. Psychiatrists can learn from neurologists and vice versa, and we're getting there slowly. I just want to thank the panel. Thank you for listening and staying and asking questions. And just a round of applause for